link to submit your CME activity evaluation, please do that. This way that's already taken care of. Otherwise, we'll send you repeated emails to complete it. If you don't fill it out, you can't get a certificate for the day. Okay, so without further ado, Nancy, they're all yours.
So thanks everyone for sticking around, and I'm going to just lighten with a quick story, which I like to tell in the previous lecture, but what we're dealing with today is that women who have created this idea that the Pap test is it, that is the reason I'm here. And I won't forget the woman who came in her bone density test showed she was osteoporotic, and we talked about treatment, went through medication, went through the whole thing. She had urinary incontinence, we went through the whole thing, but then I told her she didn't need a Pap. And she looked at me seriously and said, then why am I here? And it's like I go, okay. Okay, so the last lecture of the day, I know everybody has sat for a long time. There is an underdiagnosis of fracture risk. There is an underutilization of medication. We know that 37% of people who have a hip fracture, that is all, get treated. And that is one of the indications for treatment with medication is having had a vertebral or hip fracture. So during this talk, I'm going to go through osteoporosis management, diagnosing, and a quick question, how many of you use Frax? So I've got some hands up, but looks like maybe not even a third. So we all know who've been in practice that there's been lots in the media, and we know that patients react rather dramatically when they hear things in the media. And this article in the New York Times just a year ago was addressing the fact that people just started taking their bisphosphonates like crazy, because out came this information about these rare risks. So I think as I go through this talk today, I certainly want to let you all know that this is all about risk and benefit. We have really effective treatment for fracture prevention. To identify the right people to be treated, we also have to discuss the benefits and the risk. And I just characterize this by saying I was in Beijing, China, where you can get in like it's rush hour of bicycles and bike-driven carts. And the risk that I took in being in that cart was sure different than being on my bike path in West Bloomfield, Michigan. We make decisions all day long about risk and benefit. There's nothing new about that. So osteoporosis, this is a disease characterized by low bone mass and microarchitectural deterioration, leading to bone fragility and increased fracture risk. So this is about preventing the first fracture. If somebody has a fracture, their risk for a subsequent fracture is significantly high. Osteoporosis is a gender-related condition, and I explain to patients that estrogen is bone protective. Estrogen is produced both by the ovary and by fat cells. So we can make generalizations about body type. We know that thin women, once the ovaries are done, that's about it. Estrogen falls rather abruptly, and their fracture risk is high. Interestingly enough, just last week at the North American Menopause Society meeting, data was presented that women with diabetes, in spite of generally a body type of having more peripherally created estrogen because of fat, that there is an increased risk of osteoporotic fracture in women with diabetes. And the risk of fracture at the hip doubles every 6 years, every 5 to 6 years, there's a doubling. So age is a huge part of fracture risk. Of the 10 million Americans estimated to have osteoporosis, 80% are women. So we need to identify women at high fracture risk, but don't forget the men. The National Osteoporosis Foundation recommends that men have a bone density at age 70. In my setting, I do Medicare wellness visits on men, and it's a time that I find many men over 70 who haven't had a bone density, and I do tell them it's an out-of-pocket if it's not covered, and Medicare is not good at covering it. It's about $85 at my center. Vertebral fractures are significant for patients. Acute and chronic pain, height loss, impaired function. These are fractures at the hip and vertebrae that can take a person from independent and active to disabled and even death. Hip fractures, 30% lose ambulatory status. People know people who fractured their hip and never came home from the hospital. There's a significant mortality rate. In non-vertebral fractures, increased pain, and again, increased risk of subsequent fracture. Skull fractures and foot fractures are not fragility fractures, by the way. You may or may not know that there's something new called the Fracture Liaison Service. And the National Osteoporosis Foundation does run courses to teach practitioners to be able to work in an FLS, which are programs primarily in hospital settings meant to identify people who have had hip fractures, who generally leave the hospital untreated to prevent their next fracture. So this is a role that's up and coming, is a role, and many nurse practitioners do this role in settings to help find those people who are undertreated. So the risk factors for osteoporosis include genetic and environmental factors, menstrual status, disease states, and medication. Family history is important, slender build, many disease states, and I'm going fast through these slides because it's all available to you. I have an anorexic patient who came in thinking quite pleased that just saw her last week that she's now weighing 75 pounds instead of 58 pounds. Very scary, but she's severely osteoporotic. And after failing bisphosphonate therapy, when I met her, I encouraged her to see the endocrinologist who actually put her on estrogen. So her problem was estrogen deficiency for a very long time. We need to be aware of medications, individuals on steroid therapy, anticonvulsants, anticoagulants, immunosuppressive drugs, thyroid, lithium, and heparin. I really loved this quote from Risa Kagan, who has an osteoporosis clinic in Northern California, that over age 40, if you trip or fall from a standing height that leads to a fracture, that this defines a bone strength problem. So you've all had patients who say, but I fell. I fractured because I fell. But the fall, if from a standing height, certainly impacts whether this person is at high risk for another fracture. And this is where we need to consider therapy. And I love that she calls that a bone attack. She tells her patients that your fracture was a bone attack, and just like somebody who's had a heart attack and has risk for another one, you have risk for another fracture. So the major recommendations for the clinician for bone health is, NOF says that postmenopausal women and men age 50 and older, we need to counsel. You know, vitamin D has been a hot topic. As far as my current recommendation based on, you know what they call the specialists and the researchers in this field are boneheads. So I try to hear the boneheads as much as I can so I can take that information back to my practice. But my boneheads, I currently recommend 1,000 to 2,000 international units of vitamin D. We know that now you live in sunny San Diego. I live in Michigan. So maybe the sun exposure, but we're all paying attention to avoid over sun exposure. Also the calcium issue. We know that too much calcium is a problem, and people are probably over it. Anytime I have somebody who takes 2 supplements a day, my latest information that I tell patients is, assume every day you will get 300 milligrams just from everything. Then add your servings. Look at a few days in the life and add up. And we're trying to approach 1,200 milligrams a day. Most people don't need 2 supplements. I also tell patients that calcium carbonate products are the most common but can lead to gas and constipation, whereas citrate is the best absorbed and phosphate is the best tolerated in the GI tract. I only know of one product of calcium phosphate, which is called Posture D. So we want adequate calcium and vitamin D, supplements if necessary, weight bearing and muscle strengthening, and much of what that's good for is for fall prevention and muscle strength, and vitamin D deficiency can also lead to muscle weakness. We want to avoid tobacco smoking and excessive alcohol intake. So who gets a bone density test? Women 65 and older, and this comes from NOF as well. Men 70 and older, though not well covered. Postmenopausal women and men age 50 to 69 when there are concerns, be it due to the profile through medications and disease states. Those who've had a fracture to find their degree of severity. And we should do our bone density testing at facilities that use equipment that's been quality assured. So this is the treatment guideline as it still stands. After excluding any secondary cause, who are we going to treat? Those who've already had a fracture. We need to prevent the subsequent fracture, hip and vertebrae fracture. A T-score of -2.5 or worse. The T-score, so I know since some of you are using FRAX and most of you are not, I'm going to talk about, the bone density. I like to give my patients a lot of information, which you may have told, by the way, I'm talking through these lectures with lots of information, but along the continuum from normal through mild loss to moderate to enough to be called osteoporosis, the term osteopenia is kind of going away a bit, and in its place the term low bone mass. So we can find people with normal, mild low bone mass, moderate low bone mass, or -2.5 or worse osteoporosis. -2.5 or worse, we treat with medication. But then we know that there are more people who fracture who are not yet osteoporotic. More people with mild and moderate low bone mass fracture. We need to find those people who are not yet osteoporotic but would benefit by medication. And that's where we come to FRAX. We are told that FRAX, which is a fracture risk assessment tool that plugs a person in with their demographics of age, height, and weight, whether they smoke, take steroids, family history, fracture as an adult, and all the questions I'll show you in a minute, along with the bone density, not the T-score, but the actual bone density, and the machine that was used, is all plugged in, and against a data set, there's a calculation done by computer to determine their 10-year fracture risk. And we have strike points. 3% or greater at the hip is a time to discuss preventative treatment by medication, or 20% or greater at all sites. And that's FRAX. So using FRAX, I'm in a setting where every bone density, I have a FRAX calculation included on the final page. But what I find is data in is data out. Even though I have it calculated for me, sometimes the data that led to the calculation is not correct. If they say they had a fracture as an adult, but it was a foot fracture, I know that's going to throw their FRAX percentage higher than it may really be. So I go to the computer and recalculate when necessary. So here is the FRAX tool. If you go to the website, if you just search FRAX calculation, you get to the University of Sheffield. And when you get to the fracture calculation tool, when you get to the tool, there's a drop-down box. There's a drop-down box. You click here. In the drop-down box, you have to pick the country and the ethnicity. And then it takes you to this, for example, was a person who's a U.S. Caucasian. We have to put in get to the right FRAX. You plug in the age, the sex. If you come over here and put their weight in pounds and hit convert, it throws it over here in kilograms. You put their height in inches, hit convert, it puts it over here in centimeters. it defaults to a no on every question. Then you have to select the bone density machine, whether it's a GE Lunar or Hologic or other, and put in the actual bone density. Then you hit calculate, and you get a 10-year fracture risk. This is a wonderful way to expand decision-making about finding people at high risk for fracture who would benefit by preventative therapy. So this is an example of a younger woman, only 52, with a negative answer to all of these questions. Though she has minus 2.1 T-score at the hip, so FRAX is spineless. There's no spine in the FRAX calculation. You look at the lumbar spine scores and make a decision if she, based on those scores, but if there's no osteoporosis, it's only the hip that goes in. So minus 2.1, is that low bone mass? No. Well, it is low, but is it mild low bone mass? Well, it's actually moderate. Okay, so mild is minus 1 to minus 1.5. Minus 1.5 to minus 2.5 is moderate. So this woman has moderate low bone mass. In years long ago, maybe 10 years ago, we used to treat starting at minus 2. But guidelines have changed, and there's a much less aggressive, we used to start people on bisphosphonates. 10 years went by, 15 years went by, and we now have concerns about long-term use. So minus 2.1, moderate low bone mass, not osteoporosis. So that's why we did the FRAX, because we said, well, she's not osteoporotic, she doesn't meet the criteria to start medication, but let's calculate her 10-year fracture risk. But her age is on her side. Major osteoporotic risk over 10 years is 7.5%. We discussed preventative therapy at 20% or greater. Hip fracture risk, we discussed prevention therapy at 3% or greater. She's 1.5. So does she need preventative medication? No. So we're going to guide her and say, you already, you're only 52, you have moderate low bone mass at the hip, so I'm going to repeat this bone density in 2 years. If nothing changes, everything's the same, and even if she doesn't lose more bone mass, every year she gets older drives these percentages up. So I can tell you, put the same score at the hip on a woman of 80, she's going to have a very high 10-year fracture risk, probably well above at least 5 or 6%, because age will do that to fracture risk. So application of FRAX in the U.S. is intended for postmenopausal women and men 50 and older. It's actually been validated in people who have not been previously treated with medication. Although as a guide, I find that, what I hear from the experts is that we can still look at FRAX. It still helps us understand that individual's fracture risk. But patients who've been off medication for 1 to 2 years can be considered untreated in using the FRAX calculation. So you can calculate with either femoral neck or total hip, but femoral neck is preferred. And the calculation is really easy to do when you go on the website. Remember though, it's clinical guidance only, not a rule, and we're going to consider intervention strategies for those who don't have osteoporosis, don't meet the cut points after FRAX, and are not high enough risk for fracture despite a low bone density. But we still have to look at the whole picture, guide patients, and the recommendations do not mandate treatment. So even if her fracture risk is high, her 10-year fracture risk is high above those strike points, this is a discussion. So we know there are obstacles in managing osteoporosis. There's very insufficient diagnosis, low awareness by patients and practitioners. And then we've got that media piece of people who are afraid to take medication. How many patients have asked you, couldn't I just increase my calcium? You know, we hear that kind of talk, and there are people who have never had chronic disease and never taken medication. And I have to talk about the fact that as we age, preventative care becomes more important, and especially in those people who are at very high risk for fracture, but don't yet have osteoporosis. So what about treatment? And this was another photo from China, only for the old and aged and weak. So NOF guidelines, when do we treat? I've already talked about this. Any male or female over age 50 with a prior hip or spine fracture should be treated. And the FLS program is meant to get those people treated before they leave the hospital and miss out. Postmenopausal women or men over 50 with a score of -2.5 or lower at the hip or spine. And now new to some, also those with a FRAX, 3% or greater at the hip and 20% or greater for major osteoporosis-related fracture. So we're never going to start medication and consider it indefinite in duration. That certainly has changed. After 3 to 5 years, we're going to look at and keep looking every time we see the patient. When was the last bone density? How long has the patient been on therapy? Do you use drug holidays? Sounds like a vacation. Is anybody doing drug holidays? Yeah, so I've got just a couple people. We now are concerned about long-term use and consider taking patients off medication for a period of 1 to 2 years at times that the risk of long-term use becomes significant. We're going to look at non-pharmacologic intervention, the role of vitamin D, exercise, and fall prevention. So now I'm going to just talk about our drug therapy. Anti-resorptive agents, the bisphosphonates, the rank ligand inhibitor denosumab. In the bisphosphonates, weekly oral therapy is also the zoledronic acid. The once-a-year infusion is a great option for those individuals who have reflux, narrowed esophagus, trouble taking an oral medication of a bisphosphonate. Calcitonin, this has been around for a very long time, is a very weak drug, not in much use. And I do want to just mention raloxifene, and I'll come to that. Is anyone using raloxifene? So raloxifene is double indicated for both prevention of vertebral fracture and prevention of invasive breast cancer. It's underutilized, and I'll come back to that. We have anabolic agents, teriparatide, and the brand new abaloparatide. So let's talk about anti-resorptive therapy, the bisphosphonates. They've been around a long time. This is the drug that everybody's worried about, long-term use. There's decreased bone turnover with an increase in BMD at spine and hip. With decreased risk of both vertebral and hip fracture, it's the best studied drug that we have. It's been around the longest. The biggest problem with oral bisphosphonate is not taking it correctly. When we give the drug, as you know, it needs to be taken with a full glass of water. We have a generic, alendronate, once a week, full glass of water, no eating, drinking, or laying down for 30 minutes. The purpose of that regimen is that it not be broken down in the esophagus and because it's not well absorbed. And the problem is that we all have patients who have become older, perhaps live on their own, may have some level of dementia, but they're still doing their own medication. And the question becomes, is this patient taking this drug correctly and consistently? What's happening? How long has she been on it? What's happening with her bone density? Is she really waiting a half hour because it's so poorly absorbed? The oral bisphosphonate can be, the absorption can be reduced as much as 60% by drinking coffee or juice around it. And who doesn't want their morning coffee immediately? Calcium supplements can interfere. GI side effects are more likely when dosing instructions aren't followed, and patients may disregard part of those instructions. So then we have the option for the IV route. So IV, zoledronic acid. Interesting that this drug is used in some cancers of the bone, given more frequently in higher doses. And that's where the osteonecrosis of the jaw first was seen as an incident problem that created the concern about long-term use. The zoledronic acid, when given IV once a year, it is absorbed out of the blood and out of the bloodstream. By 36 hours, most of it has left the bloodstream. It's very bone specific, very bone specific. And it's a little scary. You have a woman who's concerned. She knows she's at high fracture risk, and you tell her you're going to give something. She's not doing well with the oral, but you can give it once a year through an IV over 15 minutes. And it's, I think, reassuring to say this goes to the bone, and it blocks the bone. Bone is living tissue, cells go in and out. We know that that's normal bone remodeling. And this drug goes to the bone, it blocks these resorption pits, so osteoclasts can't get so much bone away. It's not going to stay in your bloodstream. And if we can get it covered, oftentimes I have to do pre-authorizations indicating why the oral generic alendronate can't be used, and that could be due to GERD, could be due to it's caused discomfort, or hopefully that you know the patient is not taking it. Denosumab, a rank ligand inhibitor. This is also an excellent drug, and one of the benefits of denosumab is that it's easier on the kidneys than the bisphosphonates. And as people age and have decreasing kidney function, is also as people age, they're losing bone mass and increasing fracture risk. The rank ligand inhibitor, it develops monoclonal antibody. And another thing I like about this drug is after 6 months, the drug is actually, the effect of the drug, the antibodies have now decreased to where if that's not, a new dose is not given, you've lost the effect of the drug. And that's quite different than the bisphosphonate that is actually in the bone long term with a very long half-life. And that's one of the concerns about long-term use of bisphosphonates. I like the fact that with denosumab that when my patient has an injection, it's repeated every 6 months. There may be, in some sense, we can monitor that the effect of the drug or the decreased half-life, we're much more aware of what's happening. But the bisphosphonates are a great option. I want to mention with the IV zoledronic acid, it's important that the patient is well hydrated, that they have 1 to 2 glasses of water on the morning of the infusion. There can be flu-like symptoms. Taking preventative acetaminophen or ibuprofen is recommended before the infusion. As far as the infusion of zoledronic acid, many patients really like the fact they're done for a year. But again, because of the risk to kidney, it is important that the GFR is, I believe, above 30 to give the zoledronic acid. So you don't want to give the drug to somebody with a chronic kidney disease that's significant. Denosumab works by creating antibodies. The activation of osteoclasts is actually decreased, so osteoclast formation, function, survival is decreased. So it's a different pathway than the bisphosphonate, which is blocking the resorption pits. The difference then, but in spite of that, this drug also has risk of both osteonecrosis of the jaw and atypical subtrochanteric fractures of the femur. So those are the risks, the rare risks that we worry about in long-term use. Denosumab showed significant reduction of fracture, 68% at the vertebrae, 40% at the hip, 20 non-vertebral. So these drugs are all effective, and our choice is based on often starting with oral alendronate if able. If not, you may be filling out pre-authorizations for going to the IV infusion or to the different pathway of denosumab. There's a new agent, not yet FDA approved, which is in the same class of drug, but it is the only drug in this category that actually increases bone formation, not just decreasing resorption. And we'll have to watch to see if this drug is approved. Anabolic agents, PTH, underutilized. These drugs stimulate osteoblast activity, they're bone building. They're parathyroid hormone, and of course we know when PTH is elevated, it causes loss of bone mass, and osteoporosis. But when it's given in a pulsed fashion, it actually is bone building. So PTH improves trabecular microarchitecture, cortical thickness, increases bone mass, and decreases fracture risk. It's a daily injection for 2 years, followed by maintenance with an anti-resorptive agent. These drugs, the PTH, and I say these because we have a brand new one on the market, these drugs are meant to be used for people at high fracture risk, people who've already had a fracture, but yet are underutilized. And in the intermittent way that even though it's an everyday injection, it's anabolic and does create bone building. The pros of PTH in osteoporosis treatment, it is reduction in risk of vertebral, non-vertebral fracture. There is a black box warning about osteosarcoma, which was only seen in laboratory rats, but it's always been there as a black box warning. But if you're interested in using more PTH, they do offer programs, and the two drugs are teriparatide, which has been on the market since 2002. This is a subcutaneous injection for 2 years, and they do have programs to teach patients how to use this pre-filled injector. And I have always referred those patients on to the endocrinologist. So a brand new drug, a baloparatide, was just approved the end of April. It's very similar in terms of indication, in terms of its use, the daily subcutaneous injection, and the following that 2 years with a bisphosphonate. What I found interesting, it's a small thing, but maybe not to some patients, is that this drug does not require refrigeration, whereas teriparatide does. And for your active, young active person who travels and is concerned about that, it may be a small but important difference. So just a little bit about raloxifene, because I didn't see any hands go up. Raloxifene is in the group of drugs called SERMs, or renamed estrogen agonist antagonist. Raloxifene came about from research with its cousin drug, tamoxifen. Tamoxifen, we know, has positive effect on bone because although it's anti-estrogen at the breast, it does have bone building. It does act like estrogen on bone. We know that with tamoxifen, there's actually increased risk of endometrial cancer and blood clot risk is elevated. There has been a study that was actually head-to-head called the STAR trial that looked at raloxifene and tamoxifen. Raloxifene had in the STAR trial less blood clot risk, did not increase the risk of endometrial cancer. And the beauty of this drug is it reduces invasive breast cancer by 75% in the first 5 years and another 50% in the next 3. It was first approved by the FDA for the prevention of vertebral fracture. And then due to other data and clinical endpoints in studies, it got a second FDA approval for the prevention of breast cancer. It is underutilized, and since nobody really raised their hand or I missed one or two, I encourage you to think about this. I think the perfect patient is that woman in the middle years. Raloxifene only has an indication for vertebral fracture, not hip. Vertebral fractures occur earlier than hip, and osteoporosis at the lumbar spine occurs earlier than the hip. So you have a 50-some-year-old woman. She's postmenopausal. She's got moderate low bone mass at the spine, normal hip, and she's concerned about breast cancer. And here's an opportunity to not only protect her from vertebral fracture, but also protect her from invasive breast cancer. So there is 5% of women report hot flashes. There is a small increased risk of thromboembolic event. I recommend stopping it a week or two before elective surgery, long car or plane rides. So what happens then is you have a woman who's a great candidate for the double whammy or double good thing of raloxifene, but over time she starts to lose hip mass. Over time, she becomes osteoporotic at the hip. She's now 70. She's used raloxifene. Now her hip fracture risk is significant. This is not a robust enough drug for her. And that's where you can either transition her to a bisphosphonate or add a bisphosphonate. There's controversy about, can you over-suppress resorption? If you give 2 anti-resorptive agents, can you get essentially to a problem called dead bone, frozen bone? But my investigation of this issue is that from some leading boneheads is that it's a weak enough anti-resorptive agent that if that woman wants to stay on it for the breast cancer protection, that she doesn't have to stop it. So raloxifene, the Pro, it's a weak anti-resorptive, but it's anti-estrogen at the breast, and there's no hip data. It doesn't help vasomotor symptoms. It may, in fact, cause vasomotor symptoms. And there is an occasional side effect of leg cramps. Hormone therapy, just a word about hormone therapy. It is not approved as a treatment of osteoporosis, but it is a bone protective agent. So again, our women in the middle years, by middle, I mean postmenopausal, but in the early postmenopause, suffering with hot flashes, that's a woman who may choose to use hormone therapy. And in doing so, she is giving herself some bone protection. I want to address recent controversies in the use of these agents in the treatment of osteoporosis. There was a paper presented at an orthopedic surgery meeting that presented an increased rate of atypical subtrochanteric femur fractures in women who had been on long-term bisphosphonate therapy. And that's what led to the media hysteria. That was when the idea of osteonecrosis of the jaw, an unhealing jawbone, and these femur fractures came to the light in the media, and women started stopping their medication. What was acceptable risk previously was no longer acceptable. And if the disease state risk is high, being a fracture risk is really high. Again, it's all about weighing risk and benefit. I'm sure you all, like me, have had patients who came in and said, I stopped my Fosamax, stopped my alendronate, because I heard on the news that I might have these problems. In the meantime, she's got a -3 at the hip. And that's when we say, let's weigh and measure what is your risk of a fragility fracture versus your risk of a rare complication. So I share with you that my husband and I became certified scuba divers as newlyweds almost 41 years ago. We went scuba diving. I didn't care about the risk. I liked the fish. Then we had 2 sons, and as each son turned 12, they got certified, and we started going as a family. And I spent the entire dive going, there's my husband, there's one son, there's the other. There's my husband, there's one. You know, the risk changed. And I have to say that again. We all go through risk-benefit analysis all day long. We have to help our patients make informed decisions and help them understand. Long-term use of bisphosphonate therapy may lead to rare complications. We have to be better, because I'm not so great at looking in the mouth, and know that if we're starting bisphosphonate therapy, we may want to look in the mouth. We may want to delay if that patient is undergoing a tooth implant, tooth extraction, before I give an IV infusion of zoledronic acid. I'm going to ask about that, ask about dental history. But the dentists don't know what to do about this. I've had patients come in and say, the dentist told me to stop my alendronate for 3 months because I'm going to have dental work in 3 months. Well, what did I say about the half-life of alendronate? It's about 10 to 15 years, or about at least 10 years, 9, 10. So what does stopping it for 3 months really do? Probably not much. So there was a big review by the FDA in the New England Journal of Medicine. We know that some patients are put on these drugs prematurely, inappropriately. They don't need it. we come across those patients who can be taken off. We know that after 3 to 5 years that there may be increased risk and maybe that starts to outweigh the benefit. The long-term risks are still unknown, but I talked about drug holidays, a real important concept, that there are times we can stop the drug and then continue to follow their bone density. The American Society for Bone and Mineral Research has looked at this issue and say women should be reassessed for risk after 5 years of oral treatment and 3 years of IV treatment. Another point I want to make is this is about the art of managing fracture prevention. At North American Menopause Society meetings, which if you're involved in menopause care, it's a great meeting of everything regarding women in midlife and addresses cardiovascular, bone, every aspect. And every meeting there is breakfast with the professor where you can pay money to sit at a table of just 10 of you with one of the thought leaders. And I make it my business to do that and sit right next to the thought leader. And I did that 2 mornings in a row. And the first morning I asked about IV, zoledronic acid. Do you give it every year? And one of the leading researchers in all of bone said, no, I don't ever give it 2 years in a row. And the next morning I sat with another leading bone expert who always gives it 2 years in a row. And part of that is the art, and we need as clinicians to synthesize all of this. We need to look at the drugs available to us, the current controversies and risks of long-term use, and I'm going to now take you through real quickly that there are opinions, we are supported in practice, there's still a lot of unknowns, but the suggested approach for long-term use is based on limited evidence and does not replace the need for clinical judgment. And I call that the art of managing osteoporosis and fracture prevention. So the North American Menopause Society says that bisphosphonates are the cornerstone of treatment, generally safe and well tolerated. For most patients at moderate or high risk, benefits outweigh the risk. But the risks are rare, but we need to be aware of it. And the idea of a drug holiday is something to consider. Individualized based on a risk-benefit assessment. So a low-risk woman, I get patients occasionally, she probably never should have been put on the bisphosphonate in the first place. Her T-score isn't bad enough, she's 52, and the treatment is not indicated in the first place, discontinue. A mild risk of fracture patient, treat for 3 to 5 years, then offer a drug holiday. So this is your 68-year-old. She's not osteoporotic, minus 2.3 is her lowest score. The treatment was indicated initially, she was probably minus 2.5 or worse, but now she's better than that, and she's had 3 to 5 years of use. Drug holiday might be considered appropriate. The moderate risk patient, treat with the bisphosphonate 5 to 10 years and offer a drug holiday of 3 to 5. No risk factors, 8 years. The treatment was indicated, but you get these patients. They come in and say, yes, I've been on this drug for 8 or 10 years. It's time to do a drug holiday. But there are those high-risk patients, the 70-year-old with a minus 3.5 ongoing corticosteroid therapy for rheumatoid arthritis. She remains at high risk after 10 years. It might be that she could be on a drug holiday at some point and consider a bone-building teriparatide or raloxifene. So I'm just going to run through very quickly the fractures of the femur, the strongest bone in the body. There's still a lot of looking at the incidence of this problem. NOF has a position statement that, again, we got to look at the patient and help them understand when the benefit outweighs the risk of these rare complications. ONJ, it's defined as a delay in healing of an oral lesion after surgery or extraction for more than 6 to 8 weeks. It's not jaw pain. It's not the patient who says, I need to get off this drug because my jaw hurts. That's not ONJ. Okay, so we need to clarify that. ONJ, the incidence of these lesions is not known, but it does happen. Routine dental care is recommended for all dental surgery. There's no data to suggest it shouldn't be done in patients on bisphosphonate therapy. So before I go to some cases to close the day, osteoporosis is underdiagnosed and preventative care underutilized. So now go home and learn FRAX, go on the computer, realize that when you get a patient and the FRAX is calculated, make sure that the data in is correct or you're going to get bad percentages coming out. So let me run through a few quick cases. Your 72-year-old Caucasian woman, non-smoker, family history, osteoporosis in her mother. So I put up, these are life in the trenches. These are real bone densities that were my patients that I thought made good teaching cases. And if you can't read all the small numbers, I'll just tell you. So this is, as I said, this is a younger woman. Her lumbar spine total is minus 1.3 low bone mass. At the hip, the total hip is normal, the neck of the hip is normal, and by the way, the Ward score is a small triangle that's calculated and is not clinically significant. So when you see a bad score at the Wards, just ignore it. But here is, and I'm sorry, this woman was 72 years old, and the point of this case is that her hip score is excellent. It's only minus 0.8. Is that normal? So her T-score at the hip is normal, but now you look at the demographics. Remember, it defaults to no on every question, but her parent fractured a hip. So when this is changed, so this was changed to a yes. The machine has put in the actual bone density, the score at the hip, hit calculate, and what are her percentages? Her 10-year risk for hip fracture is 3%. What's the strike point for discussing preventative therapy? 3% or greater. Major osteoporotic fracture is 19, and it's at 20% or greater. So this is a patient who's on the ledge. She's not osteoporotic. Every year she gets older, that percentage will go up. But you can at least start to discuss fall prevention. Are you somebody who wants to be very proactive in prevention? This is a woman who may say, I saw my mother fracture a hip and die. I'd rather be proactive. This is a discussion. Now we have a young one, 52, non-smoker. She is a total lumbar spine of minus 1.5, the beginning of moderate low bone mass. Her hip score at the hip, minus 2.2, moderate low bone mass. Now we look at her FRAX. So she has a much worse T-score than our 72-year-old who was normal. This woman's moderate. But she has no yeses to all her answers here, and age is on her side. So the calculation is her 10-year fracture risk at the hip is 1.5%. What's the strike point for discussing prevention therapy? 3% or greater. So we can reassure her, age is on your side, you have moderate low bone mass, and because of that, and you're young, so we need to follow you. You need a bone density in 2 years. Would raloxifene help her in terms of hip fracture prevention? There's no hip data with raloxifene, just lumbar spine. Next case is a 63-year-old woman. T-score, spine minus 2.4, hip minus 1.6, so she's moderate at the hip and spine. Does she have osteoporosis? She doesn't. She's just short of osteoporotic at the spine. So we can now look at FRAX, but remember, FRAX is spineless. There's no spine in the calculation. But we look at her FRAX, and actually, I'm going to say she's the great case for raloxifene. She's got loss at the spine. She wants to have breast cancer protection. But now 2 years later, her bone density is minus 2.5 at the femoral neck. Now she's reached osteoporosis by T-score. Do we need FRAX? Well, we really don't, because by guidelines, she has osteoporosis. It's time to treat with medication. is raloxifene enough? And it's not, because it doesn't have hip data. So that's the patient that I would say, do you want to continue this raloxifene for its breast cancer protection? But we need to give you something more robust, something stronger to prevent hip fracture. A totally different patient, 82-year-old woman, lumbar spine normal, and lumbar spine. Arthritis can make those scores look better than they really are. So arthritis can cause falsely elevated T-scores at the spine. But nonetheless, the hip is -2. She's never had medication, doesn't have trouble swallowing, esophagus problem, only mild CKD, -2 at the hip. Does she have osteoporosis? No, she's moderate low bone mass. So what's next? What's her fracture risk? Is she somebody who would benefit by preventative medication? So I'm going to tell you that her spine is normal. We talked about her hip, -2 and -1.9. But now look at her fracs. Her hip fracs 10-year fracture risk is 6.4%. Does she qualify for preventative medication? Yes, because it starts at 3% or greater, and this is a discussion. You're not mandated to treat her. She may say, I hate taking medication. I don't want to take it. I'm not ready. Or she may say, I really appreciate that I have a high fracture risk. Your 85-year-old woman, mild low bone mass at the spine, the hip is -2.8. Is she osteoporotic? Yes, greater than -2.5. She's been on an oral bisphosphonate for 8 years, not having any problem. So here is her, the question is, would you continue her therapy? 8 years of oral bisphosphonate therapy. Is she at high risk for fracture? Would her fracs calculation make any difference? Remember that initially it is for untreated people based on a data set. But here is that typical patient. You're concerned. She's osteoporotic, but she's got long-term use of an oral bisphosphonate. In fact, it was interesting to look at her fracs for 2 reasons. One is it was reported as 17%. That's pretty high, but I also recalculated because she told me she's not on steroid. This was something in the past. So this is when I say data in is data out. Make sure that you calculate with appropriate information. So this is a patient, I said, well, let's just see what happens if I recalculate and take that out. So I removed the steroid, and she's still 11% at the hip, 10-year fracture risk. So again, the art of managing in fracture prevention. So when I removed that calculation, it became 11%, and that is a case where it is a discussion with the patient, it's a discussion with yourself. Is this the patient who I want to continue? Should she do a drug holiday? So let's look at an 84-year-old woman who's on alendronate, length of time unknown. She's had a hip fracture. Her spine is moderate loss, her hip is -3. And when we go to her fracs, I wanted you to see what happens with age and history. 39.5% 10-year fracture risk at the hip. Now this is a treated patient, so for our purposes, we can still look at fracs to get a better idea of what's going on. Will you keep her on the alendronate? Is she taking the medication correctly and consistently? What is her fall risk? What's her preference? Is she an active 84-year-old, or is she a homebound or nursing home patient? Will insurance cover a once-a-year infusion or a twice-a-year injection or daily PTH? This woman's had a hip fracture. She still has -3 at the hip. I might think about, should she have a bone building option? Again, underutilized, but these options are available. So 84-year-old, long-term bisphosphonate therapy for over 10 years, severe osteoporosis, -4.6 at the spine, -3.7 at the hip. I'm sure you've seen these patients. I said, well, here's a patient, she's active, she's 84, she has very bad T-scores, and she's had long-term use of oral therapy. I kind of thought she might need PTH. Sent her to the endocrinologist. That's one opinion, but what happened was, after all my concern about this patient, what did he recommend? He actually recommended a drug holiday. I almost fell off my chair. But long-term use, high fracture risk, but 10 years of therapy, he put her on a drug holiday. These are clinical judgments that we make. So I encourage you to, again, synthesize all the information, look at our choices, look at the controversies, use FRAX, and make sure that all of our patients who've already had a hip fracture are treated. So treasure your bones at every age. And this was a big tree I saw in Northern California. I love visiting California. And this was an old tree that's about 1,400 years old. So people are living longer. We need to protect the bones and prevent fracture. Thank you for listening to me for 2 straight lectures. Thank you so much. And I'll take questions.
We have time if anybody wants to ask any questions. I'd be happy to take any. You got tons of questions from your audience at home. Let me just throw out a couple. Anybody that wants to hang around certainly can listen. A couple questions about measuring vitamin D and treating and reassessing it. And also, in terms of lab testing, what about using biomarkers such as serum osteocalcin or urinary telopeptides to assess how adequate the treatment is without waiting to repeat a bone density test? So.
The vitamin D question, that vitamin D became such a hot topic and, becomes the vitamin of the month. There is some question about blood levels and whether it represents a steady state or not. And that's why some experts I've heard suggest that everybody should just take a maintenance of 1,000 to 2,000 international units. I think I draw vitamin D levels. I like to find my vitamin D deficient individuals, but there are some of the experts who do not think we need to do blood levels, but for now I do. And I have to say about the urine NTX and looking at markers of bone turnover, it is something I dabbled in some years ago, and I think the question is, if we're going to withhold a therapy because it has a very long half-life and do drug holidays, would it be of help to know what the bone turnover is doing? So we expect that bone turnover, it is at a level during all of the years of life that is above a certain level, but if we go on put on an anti-resorptive agent, we decrease bone turnover. We should see a decrease in the NTX level and so on. But there's not a lot of support for using these markers in practice at this time. I can think back, I used to do it, and I can't remember the last time that I did. Certainly endocrinologists, people in research probably do use these markers much more than I do in clinical practice. Yeah.
Following up, somebody just asked about the vitamin D, whether or not all African Americans should be considered in that pool, if they should get it as well. But along the vitamin supplements, someone was asking the use of vitamin K2 in the prevention of osteoporosis.
Yeah, I must say I'm not an expert on vitamin D, so I would probably have to defer that question. I will say it's kind of fascinating because as we look at what's being published, I found just fascinating. There was a study that showed that there was more bacterial vaginosis in women with low vitamin D levels. And I thought, boy, that's exciting. Wouldn't it be nice because we could, if we raise vitamin D and get rid of something many women struggle with. But we're still learning. And some of my remarks, I make it my business to hear as many experts as I can so that I can go back to my own practice and also be able to talk with other clinicians. But there is varying opinions. And I will tell you, one of the leading bone researchers happens to be in my community. And I'll say 10 years ago, he said, I never do a vitamin D level. Everyone just needs maintenance. And we all went like, wow, that sounds so off the wall, and now it's kind of circled back that I'm hearing others say that. So we still have a lot to learn.
Someone's asking about how you get around Medicare for doing screening, osteoporosis screening, and how to get it covered through Medicare. What do you code it?
I have no insights into how to get it covered. As I've said in my setting, I tell, because I see men for Medicare wellness visits, and I do order bone densities, I just make sure they understand the importance, and that the out-of-pocket in my where I am is $85. It's not thousands. Mm-hmm. And that it is, if they do have bone loss, it's submitted with that, and it's generally covered. If it's normal, they may get an out-of-pocket cost. But I stress the importance, because we, again, you know, I say this to patients every day, we don't feel bone loss. We feel arthritis where bone meets bone, but we don't feel even if we're at a very high risk for fracture. And we need to help our patients understand that.
Any comments on men and testosterone deficiency? Someone just commented.
Just that most of our drugs do have an indication for men with osteoporosis secondary to hypogonadism. So it is an important area to be aware of, that there are secondary causes of bone loss and low bone mass, and it's part of our workup. Yeah.
Hi. I'm just wondering, are you going to be very comfortable starting biphosphonate with patients having osteopenia only? Not osteoporosis, but osteopenia.
Well, the question being that our practice is supported by NOF guidelines and NAMs, that those are the indication to treat with a bisphosphonate is either osteoporosis or the 10-year fracture risk being 20 at all sites and 3% at the hip. So there are patients who are osteopenic or have low bone mass. That's why I use FRAX, is to find those, so again, to find those patients at high risk for fracture who do not yet have osteoporosis by their T-score. And those patients need to be treated preventatively in many cases, and with a discussion with the patient, and risks and benefits. Yeah.
I have one last one here. Are you familiar with medical foods such as Fostium for osteopenia prior to osteoporosis? I've never heard of that before.
I've never heard of
Anybody here
that.
of Fostium? They wrote it F-O-S-T-E-U-M. Anybody want to comment? Sorry, whoever wrote this question at home, we don't know the answer. Fostium? No, this is for a supplement, it sounds like. Okay, sorry we can't help. Okay, well, if nobody has any other questions, let's thank Ms. Nancy Berman for an awesome presentation today.
Thank you, everybody, for hanging out so late today.
Great, thank you. Thank you. And for everybody at home, thank you for spending your day with us. Submit your CME activity evaluation forms online for everybody here. Bring them up to the front desk, and we'll see you at the next NACE event. Thank you so much, and enjoy the rest of your weekend.